and 314 for a shooting at Century Theaters. They're saying somebody's shooting in the auditorium.
Roger, keep your fires west of the smoke. You're cleared hot. An officer hit. Send me the world.
Don't go over that fence. Don't go over that fence. Grab the shotgun again.
Welcome to Tactical Tangents.
Welcome back to Tactical Tangents. This is Jim. This episode is brought to you by Drip Drop Oral Rehydration Solution. Drip Drop is formulated by a doctor for quick absorption of water into the parts of your body that need it. You can find it on dripdrop.com or even on Amazon. If you're military or law enforcement and your organization is training or operating where it's hot, have your supply guy buy it for you. It's available on GSA Advantage and through the National Stock Number System.
And this is Mike. This episode is also brought to you by Mantis. Mantis is a firearms training system that works in both live fire and dry fire training. Their newest products can track your recoil management and help you refine your draw from the holster. Some of their newest stuff also works for shotguns and archery. If you're into those sorts of things, you can check them out at mantisx.com for data-driven performance. So, Jim, tonight I want to talk about a topic that is probably pretty well overdue, and it has to do with trauma care and medical care in general. And it's a little bit overdue partially because, I don't know, it's an area of passion for me. And as a guy that wants to teach it, I want to teach all the things. And so I have to break it into bite-sized chunks. Mm-hmm. And one of the other challenges is I'm trying to teach to, I don't know, 3 or 4 different audiences. If you think about people listening to the show who might just be everyday carry, survival, self-defense oriented people who don't really have any background in this at all, or police officers who have very basic, really entry-level first aid, first responder type stuff, but nothing beyond that. And then also your paramedics, EMTs, and firefighters who might do this professionally for a living. And I want to bring value to them as well. In other words, I want to give them like a way of thinking about it, or our perspective or our spin on things in a way that is also valuable for the guy that has never heard of some of this stuff. And then there's potentially some, nurses or other healthcare providers out there that are listening to this that it's certainly more basic than they need, but with a more tactical flavor. And so I think this is something that I finally am just like in a spot where I'm like, let's just take this bite-sized piece of it and start cracking this open. And my approach to it is kind of like the fitness episode that we did a little while back.
Get you started, right? This is a tough topic because there are a lot of barriers to entry. There's, it's relatively easy to go get a CPR class, and a lot of people don't even do that, right? Or a basic first aid class. And a lot of what you get in basic first aid is good, but it's very, very limited because it's a big commitment to get to the next level of training, something like an EMT level of training, and then big commitment to jump up from that into the next levels of professional healthcare providers, right? And I think a lot of people have had some exposure to first aid. They either took it in like a health class in high school, or they were lifeguards, or in basic training in the Army in 1979, they got taught, self-aid buddy care, whatever they called it back in the NOM. And, one of the problems with medical stuff is it changes. Our understanding of it changes. So stuff you might have gotten taught 10 years ago just isn't true anymore. We've seen a drastic change in things like tourniquets, and we're going to talk about that as we go. But that's a good example. And so I think this is a hugely important topic. And I think one of the reasons it also stops people is this kind of a goofy fear of legal liability. We know that medical and legal are both these big, scary professional worlds, and we want to stay away from them as much as we can. And that's great up until you have a medical emergency. And this is one of the tricky things about the tactical world is, what are the odds you're going to get in a gunfight in your life? Well, for most people, very, 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 very low. Even for most cops, very low. Even for most military people, very low. I mean, there are some professional gunslingers out there. Their numbers are different. most of the people listening to the show are very unlikely to get in a gunfight, if we're being honest. However, the odds that you're going to see somebody really hurt, or that you're going to get really hurt in, like, I don't know, a car wreck, pretty good. That's trauma, right? So I think you need to account for that in your overall risk management and your prep outlook, no matter what your background is, whether you're military, law enforcement, or civilians of carry. And you need to understand legal liability, right? We're going to talk about all kinds of medical stuff. We're not giving you medical advice. We're telling you go get training. And you need to understand what your liability is if you intervene, in a first aid context. And in most places, you have at least some protection. And that's one of the reasons it's important to go get formal training, so that you know what protection you have in different places and different settings. Generally speaking, if you're working within your training, you're probably going to do okay.
Yeah.
It's when you go off script, you're going to have problems.
Yeah, and this is an area that, when it comes to liability stuff and trying to keep yourself out of trouble, at the end of the day, if you act in good faith, generally speaking, you're going to be fine. And healthcare providers in particular get a lot of training that is centered around standards of care and some of the legal stuff. And you want to know why that is? It's because they work for people with money, right? They have employers, right? They work for agencies or corporations that have deeper pockets. And so they have to worry about that stuff, because someone somewhere is always going to try to get into those pockets. And I'm not saying that you should completely ignore that stuff, but I am saying that if you just put in the back of your mind that you're going to do the right thing and you're not going to go, like Jim said, terribly off script, you're going to probably be fine. So, don't get too bogged down.
And it shouldn't be a barrier to going and getting training. And I want to reiterate, a podcast isn't going to make you a medic, obviously. Our points are here to help motivate you to go get training. If you don't have anything, go get something. Go get first aid. Go get CPR. If you've already got that, go get the next thing. If you've already got that, go get the next thing, right?
Yeah.
Our goal with this podcast is give you some insights so that you get more out of that training when you go to it, help inform your decisions and refresh you if you already have some training, but more importantly, motivate you. Go get training. Go get more training.
Exactly. So I want to get into some of this stuff, and what I want to cover as it relates to trauma care, there's a little bit about the why. Why do I isolate trauma and not just medical stuff in general? Well, medical stuff in general is also important. I think it's worth learning a little bit about allergic reactions and cardiac arrest, and what to do if someone's having a heart attack or a stroke, or they get stung by a bee and they're deathly allergic. Those things are all also important. But trauma is the leading cause of death among people who are 1 to 44 years old. So that's a big span of life and age and life expectancy.
So words mean things. When you say trauma, do you mean like
injury? Someone
said something mean to them and they were traumatized by it? What does trauma mean, Mike?
Yeah. So we're talking injuries, right? So not medical causes of death. We're talking about things like car accidents, interpersonal violence, falls, those sorts of things. Trauma in one form or another is the leading cause of death among people who are 1 to 44 years old. So I tend to isolate a lot in the trauma realm as a personal area of interest for mine, not only because of that, but also because as far as things that you can actually do something about, a layperson, a bystander, a EMT paramedic, there's a lot that you can do in the realm of trauma that can affect those outcomes. If someone is having a heart attack, they need to go to the hospital. And in trauma, that is also true. They need to go to the hospital, right? Definitive care, bright lights and cold steel, as they say, and we'll get into this a little bit later, but bright lights and cold steel, definitive medical care is the long-term goal of your interventions, right? But there's a gap of time where if you don't do the right things, that person's not going to make it there. And if you do the right things, you're increasing that person's odds, not only of living and surviving the injury, but also not having permanent disability or, brain damage, those sorts of things that last as a result of it. So trauma is, again, one piece of the puzzle, but it's why I think it's an important one and one that we're going to start to deep dive a little bit here, again, just as a primer. So before we get into the nuts and bolts of trauma care and the medical stuff, the one thing that I want to make sure I mention and refer you guys back to is the episode that we did back in the day with Dr. Tang. And he's a trauma surgeon that works here he's actually the head of trauma surgery here in the town that I work at, one of our big hospitals. And he came back on the show. Gosh, it's been a couple years now. It was a pretty early episode for us, I think.
Yeah. But we went and found one of the most qualified dudes in the country to talk about trauma stuff. So it'd be a shame not to go find what he has to say about it, because he's a brilliant dude. It was cool to listen to him.
Absolutely.
Yeah.
So many of the people listening to this show have probably heard the term March before. And March is an algorithm. We've talked a lot about decision making and algorithms in general on the show. And March stands for massive hemorrhage, airway, respirations, circulation, and head injuries / hypothermia. And this is an algorithm that many people use, especially in the tactical realm, for dealing with trauma care. Most of you, or many of you, not to insult anybody's intelligence, but have probably heard of that or read that. The type of people that listen to the show, if you've taken a class, it's probably come up before.
Or some variation of it. It has evolved over the years. Back when you took it, if you took it a couple years ago, you might have heard the ABCs or the AABBCCs, some variation of that. This is the most current version of this, and it's going to evolve from the time we record. You're going to hear something else in a year or two, and that's okay.
Yep.
That's kind of the cool part about getting training, is staying current on this stuff.
Yep. So like Jim said, you had the ABCs back in the day. That's kind of how this evolved from. And ABC is nice because it's in alphabetical order and it's easy to remember. And it stood for airway, breathing, circulation. And we started kind of expanding on things. And then there was an extra A and an extra C. And then, and then at some point, people want to create something that's easy for you to remember. And so it was like A squared, B squared, C squared. And then it became A, B, C, D, E, LMNOP.
There was a 10-4 in there somewhere because the cops got involved.
Y and Z, yeah. I mean, it just kind of got out of hand. And so where we're at lately nowadays is March. And so the idea here is it's an algorithm. It helps with your decision-making to guide and inform your decision-making somewhat. And if you've heard of that, that's cool. We're going to cover it. But more importantly is I want to get into the field care mindset. And even if you are a well-versed combat trauma medic, whatever the hell, I want to make this relevant for you too. So if you've heard of March, if you know March, I don't want you to just hit stop right now. Like this is shit that I already know. I want you to think about the mindset that comes with it. Okay. And for the people that have never heard of it before, which hopefully there's a few out there that this is your introduction. What I want you to know is that if you listen to this episode and you know what March stands for at the end of it,
that's a good start. I will take that.
It's a good start.
Then let's go past that, right?
You ain't ready. Yeah. And this is something a lot like tourniquets. Jim mentioned tourniquets a little bit earlier on, and there was a period of time back in the day where tourniquets were just like a normal thing. And then at some point people said, oh, well, they cause tissue damage and it's like life or limb. And so they were kind of frowned upon. And then at some point people came to their senses and understood that they have a place. And we made some tweaks to tourniquets from a technology standpoint that actually made them like a life-saving tool. And they're a critical part of, especially for trauma, they're a critical part of trauma medicine today. But just because you know what a tourniquet is and you know how to put on a tourniquet, that doesn't make you a medic, right? Anyone can put tourniquets on. And this has to go beyond the gear. Like anything that we talk about, this is more than just a hardware thing. And having a kit, again, like anything that we talk about, survival is not a kit. It's not something that you put in your backpack. Survival has to do with problem solving and techniques and training and a mindset. And I'm careful when I say mindset, because mindset's not a verb. You don't mindset someone into the ER or the OR for that matter, operating room. But the way that you approach training and patient assessment and patient management as it relates to trauma is important. Now, one of the big limitations in the law enforcement setting and my line of work as a tactical medic and what I do as an EMT who works on a SWAT team is when we talk about tactical medicine is we're making certain assumptions about the operational environment. And that's that it's tactical, quote unquote. And whether that means it's about a gunfight or it's about any kind of fighting environment, right? Gun battle, combat, austere environments, whatever you want to call that. The thing about it being tactical is that it presents unique challenges. And so we get into that problem-solving state of mind that is unconventional. And what I mean by that is in a traditional urban Western culture, you've got whatever medical trauma situation that occurs, people call for EMS workers who respond to the scene. They come with an ambulance, they load that person in an ambulance, they take them to the hospital. Where things get tactical, we start looking at things like, well, those EMS workers only respond to the scene if the scene is safe. And so we have to make the scene safe, or we have to remove the person from the unsafe environment to bring those EMS workers in. And where most of this tactical, quote unquote, stuff comes from in the battlefield combat fighting sense has to do with being overseas, right? In you're at war and you're out on the objective, wherever that might be. And you've got to not only deal with the casualty right here on the battlefield, but now you have to start thinking about getting that person from the battlefield to a safe place where you can treat them. And then from that place to, basically back home, ultimately to definitive care, right?
Yeah. And think of all of what Mike just said, you have to unpack a little bit, right? So what works in a car accident in your hometown doesn't necessarily work in a school shooting in your hometown because I can't get the medics to it, right? What works in the United States doesn't work in countries that don't have the level of emergency medical services that we can provide. What works in a really, really rural environment, even in the United States, is different from what you get in a big city, right? And so part of that mindset is understanding your operational environment. Where am I? What are the risks right now? And what resources are available to me if somebody gets really, really hurt, or if I get really, really hurt. And then that just gets that much more complicated in combat when people are shooting at you, and fog and friction and all the stuff you have to wear. One of the things that has evolved with things like tourniquets is body armor and helmets. Body armor and helmets changed what injuries are survivable and which ones aren't. They also changed what the most common traumatic injuries we see are. It's one of the reasons tourniquets became such a bigger deal, is because your torso is protected under body armor. Your head is mostly protected under body armor. So facial injuries and extremity injuries become a bigger thing when you're talking about guys who are armored, kitted up, right?
That's all true. And one of the other parts of this is what you are used to. Let's say you're an Army combat medic working a convoy driving through, I don't know, somewhere in Iraq. And I know that's not like a thing that is happening right now, maybe, but just,
yep.
but I think, yeah. And I think most of the listeners can probably appreciate that sort of scenario, right? And you've got that experience and that training and whatever. And now you come home and you find yourself, you happen upon a bad car accident. Well, the tactical part for you is now applying those skills that you have in context. Yep. And so this matters if you are a traditional or conventional paramedic, EMT, registered nurse, ER doc, whatever. and you are on the side of the road by yourself without any supplies on that car wreck. You're not in your wheelhouse. You know, you're in a unconventional position for you. And if you're a EMT or paramedic who works on in the fire service or on an ambulance all the time, and you go to car wrecks all the time, you're pretty familiar with what's going to happen next, but you might be limited on resources and supplies you have with you. If you are an ER doc or a trauma surgeon for that matter, and you show up on that scene, that's not something that's normal for you, right? So there's a lot that goes into the mindset of whatever your wheelhouse is that you want to figure out how you can apply those. So in tactical medicine in general, the way that they split this up, and if you take a TCCC or TECC, that stands for Tactical Combat Casualty Care or Tactical Emergency Casualty Care, which basically mean the same thing, but one's intended a little bit more for like a military setting and one's more of a civilian stateside sort of setting, right?
One's a little more shooty, one's a little less shooty.
A little bit more, a little bit less, yeah, in a sense. They kind of categorize their stages of treatment as direct threat care, like you're currently getting shot at, you're in the middle of a gunfight, and you've got casualties. Indirect threat care, or situations where this is still tactical, the bad guy's around.
There's a danger, but it's not actively shooting at you.
Yeah, and I've got some time and space to work with, right? Or what you might consider relative safety, right? It's not safe, but it's safe-ish. It's safe for now. And then you've got casualty evacuation, which is all about, more or less getting off the X and out of the safe or out of the unsafe zone and back home to definitive care. In all of those situations, what you're trying to mitigate are the limitations in time, resources, personnel, safety, security, equipment, all the things that you cannot assume are a given as if you were in a hospital bed in an emergency room at a trauma center, right?
And one big one I want to interrupt with is lighting. And that's one of the things, like we talk about fog and friction and being out in a field environment, whether someone's shooting at you or not, just lighting. Not being able to see what the hell it is you're doing, not being able to fully assess the casualty because you can't see. And even if you have a flashlight, you're not seeing perfectly, or you're not seeing the entire scene. It's stuff like that you're going to have to work around. It's being in a dirty environment, right? Because people are dirty, humans are gross, and then they get hurt in, something other than a laboratory environment, something other than an operating room. And you've got to deal with that and try to keep them clean and yourself clean. Ugh.
Icky. There's a rule as far as like personal protection goes from bodily fluids. If it's wet and it's not yours, don't touch it. But so while March or ABCs or whatever we're going to call them would seem like a prudent area to get into, the reason I bring all of that up is to consider the operational risk management model, ORM, where you talk about identifying the hazards and then identifying ways to control or mitigate those hazards. The same sort of thing goes into the types of scenarios that you might find yourself in. So if you're just an average Joe Schmo citizen and your day consists of driving 20 minutes to and from work, what are the sorts of environments that you're likely to come across in that 20-minute drive? And then during your time at work and or the time or the things that you might do on the weekends with your family when you're out and about, you have to ask yourself, where am I going to be? What are the circumstances in terms of, do I have any equipment that's going to be with me? Is it just the stuff that I'm carrying on my person? Am I going to have a first aid kit or a trauma pack of some form, some cache of supplies tucked away that I can access? Or is what I have what I have? Am I better off taking that casualty or injury and driving somewhere? So in a rural setting, you're a little bit more on your own. You want to be more self-sufficient, where if you know that you work and live 5 minutes from a fire station, you only have to generally speaking, survive that 5 minutes, right? So this is where you have to kind of apply critical thinking before the disaster, before the emergency, before the ABCs, and ask yourself all of these questions. The reason those things are important is because when it boils down to the situation, as it were, whatever situation you happen upon, you have to frame all of your skills, all of your supplies, all of those resources in context. So I want to talk about the phases of TCCC or TECC. I mentioned these already: direct threat care, indirect threat care, or what some books will call tactical field care. This has a lot to do with the setting, right? Yeah. I mentioned the civilian settings versus the combat overseas settings.
But anytime you hear Mike say TCCC, I want you to picture an actual gunfight actually in progress. Dudes shooting at each other, dudes shooting at you, an active school shooter type event, where the environment is inherently unsafe. And there's a lot you can do when you're in a relatively safe environment. There's a lot you can't do when people are actively shooting at you. So when you hear TCCC, I want you to picture people actually shooting. Once the scene is safe, once the threat is down and you're reasonably confident that the threat is down, it transitions from TCCC to something else. And there are a couple different versions of something else, but TCCC, people shooting.
And this is why it's important, because let's say you're a conventional EMS, paramedic EMT, you work on an ambulance or a fire truck or whatever, and you go to that school shooting after the fact, and you're dealing with, all right, I got these patients, these are their injuries, I just got to, sort through my triage in terms of the mass casualty, start rendering aid, transport those people to the hospital in the most appropriate order and manner, right? Pretty straightforward. We're making certain assumptions. We're assuming that the scene is safe. And so we have to kind of break that down into these phases that TCCC talk about. So if the shooting is actively occurring, right, direct threat care, and you are just some Joe citizen bystander on the scene, and let's assume that you have some, felt duty to intervene, whether that means render medical aid or respond to the threat or whatever, right? The most effective medicine, the way that you prevent more loss of life, is by intervening with that threat. Effective return fire, right? The best medicine, the best medical treatment that you can provide is to eliminate the threat and loss of life, okay? You also need to effectively use cover and concealment, which is not the topic of this show, but you want to think about ways that you can move to safety and get yourself out of the kill box or off the X.
Yep. There's a truism in combat that dead bodies attract more dead bodies and injuries attract more injuries, right? So anytime someone gets hurt, they stop. And stopping is inherently dangerous. It's more difficult to hit a moving target than a stationary target. So if you're hunched over someone trying to help them, you're a stationary target and you're usually an exposed target. So I'm not saying don't help them. What Mike is saying is kill the bad guy, then help them.
Yep. Yeah, so effective return fire, eliminate the threat are good first steps if this is a direct threat environment and there is an active threat to your safety, right? Use good cover and concealment. Try to protect yourself to the degree that you can. Eliminate the threat. Get out of the kill zone or off the X. And in those situations, minimal interventions are going to be appropriate. There's only a few things, you're very limited on time, and there's things that demand more of your attention to prevent further loss of life before you can get too far in the weeds on the medical treatment.
And if you're the one who's hit, remind yourself, hey, I'm hit, but I need to keep fighting and I need to keep moving, right?
Yeah.
And if your buddy is hit, you need to remind them, keep fighting, keep moving. Try to get them to move, right?
And the components that play into that really well are making sure that you can self-treat and making sure that your buddies and your teammates can self-treat and encouraging them to do so when it's appropriate, right? So let's assume that there is a active ongoing gun battle maybe somewhere nearby, but that is not immediately affecting you. You are in a situation where there is a threat out there, but it is not directly imminent to you, right? Indirect threat care or tactical field care, settings where, yeah, this is still a tactical, fighty, defensive
There's a generalized
environment.
danger.
Yep.
But they ain't shooting at you.
But we can mitigate that a little bit because we're behind cover and it's away from us. It's separated by some distance or whatever. And that's when you start getting into some of your treatment. But a big part of the emphasis there should be on thinking about the next steps. Yeah, let's render aid. Yeah, let's make sure that we can stop the bleeding that we can stop. But we need to be thinking about the next steps here. We need to get out of here, right? We need to get to a safe place where we can really focus on the treatment and care of this person. And we can start to get to the intermediate steps between us and definitive care. Now, I want to stop here and get into the definitive care thing. A lot of my EMT and paramedic bros, and I'm sure I've been guilty of this in the past, and on any given day might be guilty of it again, but we've got lots of skills, right? We got mad skills, right? We're kind of a big deal, right? Our office smells of rich mahogany and all that.
You're a healer. You're a medic.
Yep.
You're a
kind
shaman.
of a big deal. Yeah. So we want to use all those skills that we got. We got a whole bag of tricks, right? Big bag of tricks with all these cool things that we can do. And we've been taught, we're certified, no big whoop or anything.
And you have the literal bag of tricks, right? You got that Ranger Ricky rescue bag full of stuff
Ricky
you've been
Rescue.
carrying for the last 2 years.
Yeah. And so in our well-intended minds, we want to do all the things, right? Oh man, I could start IVs, I could drop airways, I can do this, I can do that. I could even check a blood sugar. Check this shit out, right? The problem with all of that is if someone has trauma, especially if we're talking about penetrating trauma like stabbings and gunshot wounds, if it's not a bleed that you can stop right there with what you have in your hands and they need surgical intervention, then you are on a clock, my friend. And that clock is the factor, right? Time. And back in the day, they used to talk about the golden hour, where you're like, generally speaking, we want that like 60 minutes. You can't guarantee that person has an hour, right? You need to compress the amount of time it takes that person to get to surgical intervention as much as possible. So that means bright lights and cold steel is your objective. Your objective isn't using your mad skills. Your objective is getting the person to that operating room. And your mad skills might help bridge the gap. So I'm not saying don't use them.
Buy them time.
Right.
But get them
saying
moving.
You want to use them in context and make sure that you're staying focused on that bigger picture, right? So coordination of care is a big part of this. So you need to be thinking about the next steps, especially in that indirect threat tactical setting, the warm zone, if you will, where, I'm not really getting shot at, but I know that like the ambulance might not just necessarily roll right up here where I can load them into the back of it. So I might need to think about moving the person or making the environment safe enough that I can get help to me without creating more casualties, right?
Scene safe is a term that is like a given in the emergency medical community. It's something that, as I understand it, is beat into most emergency medical providers. It's doctrine for them. It is, do not make yourself one of the casualties, right? And that's not just trauma. That's everything. That's if there's a train derailment and it's giving off toxic fumes, you don't want to go right into it and become one of the dead guys, right? So they get taught, scene safe. Make sure the scene is safe before you approach. If there's an active shooter, make sure the cops tell you he's down before you go in. So that has come as kind of a surprise to victims of violent events when they call 911 and they expect like the cavalry is going to show up and the medics are going to show up, and then they don't for whatever reason. So understand, scene safe is a big deal. It's a doctrinal big deal. And again, you might need to make the scene safe, or you might need to take people out of the unsafe scene. The term you might hear, and you've heard Mike kind of allude to it, is a hot zone or a warm zone or a cold zone. As emergency medical providers have evolved, they've started to figure out, well, how can we push the bounds toward that unsafe situation? And the answer is, well, again, this kind of indirect or tactical, something in the middle, something where we're not totally safe, but we're not actively getting shot at. Maybe we can collect the casualties there, right? So there might be a warm zone or a cold zone. So you might need to think about that. You might need to start building out that space for them.
Yeah, and this is, going into the quote unquote mindset thing. And again, like, you don't mindset your way through this. This is a thinking person's game. And the reason that I'm bringing all of this up in the context of TCCC is it applies even if you're just it doesn't have to be tactical, right? Just civilian EMS world, or bystander first aid world. It goes beyond. I have a minor gripe that I should probably just talk about right now.
Just one?
There's just one. Totally, okay. Just one. There's an image, like a little infographic that I see every once in a while that's got like a human torso, and it simplifies trauma care where it talks about tourniquets on the extremities, pack the junctions, seal the box. And the box is like the torso where you put chest seals on wounds over the box. And the extremities are obviously the arms and legs. And then the junctions are like the groin and armpit areas where you're going to do wound packing. And it's like it simplifies trauma care in those basic, like, tourniquets on the extremities, pack the junctions, seal the box. Okay. Well, just knowing your ABCs isn't really enough. Like, you can start slapping on chest seals and tourniquets and packing wounds, but that's not what saves your patient's life long term, right? You've got to think about the bigger picture here. And what's involved in that is saying, how much of this can I and should I do right now, working our way towards that bright lights and cold steel thing. So agility is a big factor here. The circumstances can change, right? The third phase of TCCC, just to back up just a little bit and talk about what happens after the indirect threat or tactical field care, is the casualty evacuation phase, which is where we're actually talking about getting that person where they need to go, right? And there's a lot to unpack there. We can talk about, should they go by helicopter? Do they go by ground? Do we have to drive them somewhere? Is someone going to come to us? And depending on your environment and the circumstances, it's probably beyond the scope of this episode, other than just, call 911 and get those resources to you, or get on the radio and get those resources to you. But what I want you to think about is that flexibility or agility component, which is, hey, this guy needs a helicopter. He needs to get to a trauma center right now. Well, the weather's shit. We're not sending you a helicopter. Okay, get in the truck. Boys, pack them up. We're moving. And we go to somewhere where the helicopter can get to us, right?
Same with just have an understanding of helicopters, right? In general, if you can find a wide, open, flat space, that's a good start. Picture a football field. Now, there are lots of helicopters that can land on a lot smaller spaces than that, and that's true. But gosh, if you can get to an empty football field or soccer field or something like that, that's a good start. Flat, open. Look for things that are going to hurt helicopters if you can. Power lines are not good for helicopters. Trees are not good for helicopters. Landmines are not good for helicopters, right?
Especially if there's a football field between you and the trauma center, right? That you can kind of bridge that gap a little bit.
Yep.
Maybe you can get them there at least and get them a little bit closer, because you know that the guys on the helicopter are sitting at a station somewhere and need time to spin up and launch.
Exactly.
And get out the door.
And that brings up the rescue process. So military people, generally speaking, are taught, like the CASEVAC 9 line, that there's certain items you need to pass in order to get the rescue helicopter to you. Big picture, mindset, no one's going to come save you if they don't know you need saving. You've got to get the emergency call out, and you got to give them good data. You have to tell them how many injured, where they are, what are the conditions when they get there, right? Just that, which is, by the way, about half of the Medevac 9 line, is a good start. So get the emergency call out, make sure they know how many patients, how bad the patients are, and we can get into the details, like the missed reports and stuff like that. You can Google that if you want. Big picture, they need to know where you are, and they need to know what they're getting into on the way in.
Yep. So I think that mostly covers the phases of care. And I know we didn't like draw hard lines in between those things. And that's because in real life, there aren't hard lines. If you are a police officer who gets in a shooting, that's tactical for most police shootings, most officer involved shootings. It's an exchange of gunfire that lasts a number of seconds and then it's over with. And now it's back to conventional EMS stuff, right? Now you don't want to put all your eggs in that basket. Sometimes you could have a long drawn out gun battle. Sometimes you can have unique types of threats and you got to plan accordingly. But the idea is that flexibility and agility component, you're asking yourself all of those questions to problem solve. And that goes, and the reason I'm bringing all of that up is it goes beyond the scope of the ABCs or the march when you get hands-on with your patient. And a lot of that planning and decision-making process and problem-solving can happen before the event. When you start going through the list of what are the likely possible scenarios that I might experience in my environment, whether I'm a police officer, firefighter, civilian, concealed carry person. Do I live out in the middle of nowhere in rural territory? Do I work in an urban setting where I'm mostly no more than 5 or 7 minutes away from the nearest fire station or trauma center? Those are the questions you have to ask. So, basic questions to consider for your worldview on trauma care. Where is the nearest trauma center? And let's talk about the difference between a trauma center and a hospital. A trauma center, as designated by, there's a whole accreditation process for a hospital to be designated as a trauma center. And what it basically involves is the availability and staffing of an operating room for a trauma patient. If someone needs surgery, how long is it going to take to get the people there and the resources needed to spin that thing up? And if that is always available, then that is going to be a level 1 trauma center. And that's generally going to be your best destination for people with trauma. Not always, there's some exceptions, but in your area, you should know where the trauma, which are hospitals, where the nearest hospital is and where the nearest trauma center is, and understand that those might not be the same thing. Now, when I was new on SWAT, we would do these operational briefings and they'd say, and if we have a casualty, we're going to take them to the nearest hospital, which is here. And this was before we had really developed our tactical EMS program, where I was a new medic on the team. We didn't have like fire department paramedics like we do now and stuff. And I used to, again, when I was kind of new at this, try to interject in those briefings and say, hey, just going to the nearest hospital is not a great idea. It's better to go 5 or 6 minutes further to a trauma center where they have a blood bank on standby.
Fresh whole blood.
And surgeons sleeping somewhere.
Yep.
Where, you go to the nearest hospital and they might have to call a guy at home to come in and fix you. Or, get this, believe it or not, they're going to call an ambulance to take you to a different hospital. That happens.
Yep.
Okay. Best case scenario, there are some times where in like a rural environment, you'll have a hospital where they're the nearest hospital and the next trauma center is like really far away. And then you get some doctors who,
Mike, actually.
You do.
So,
and before you say that, I just want to say that those hospitals might have some doctors that get a little sporty. And I'm not saying that they're doing anything unethical or wrong. I'm just saying they're doing the best they can with what they got. But it's because they're not surgeons, but they know that their patients might not make it that far. So I think it's worth researching and understanding what the difference is in your area.
Yep. So this one time at band camp, there was a ground special operations team doing training out in a big open training range in rural Southwest. The special operator was driving a big souped up all-terrain vehicle, ATV 4-wheeler, and it rolled on him. And it rolled on top of him and broke his collarbone, broke out some teeth, broke his hand real nastily. And they were working with a helicopter. So the helicopter did what helicopters do. They landed, picked him up, threw him in the back, just like they were taught, right? Good train like you fight kind of thing. The helicopter took him to the local hospital. Oh, actually, no, wait. couldn't take him to the local hospital because the helicopter was too big to land at the local hospital, landed at the big airbase. Was met by an ambulance, and it took some coordination to get the ambulance to the helicopter on the flight line. They then transloaded him from the helicopter to the ambulance. The ambulance drove 30 minutes to the local hospital. The local hospital said, hey, this is trauma. This is in our bag. They put him back into the ambulance and drove him 100 miles to the trauma center. And if they had just stopped and thought about it, the helicopter either could have flown all the way to the trauma center, or they could have stopped, said, hey, this is a training thing. We're operational. Let's have the local guys who actually know the local emergency medical capabilities, and had a civilian helicopter come get the guy and take him to the trauma center. Mm-hmm. And the difference is, what should have been a golden hour became a golden 4 hours. And thank God he didn't have anything worse wrong with him. He's probably pretty nasty looking now, but he's not dead. But the reason he's not dead is not because of anything we did for him. And that's really frustrating.
Yeah. And that's the thing, is you have to see if your overall definitive care timeline is going to be compressed by just going to the most appropriate facility. And if you don't work in a setting that deals with EMS and transport stuff, that's probably not something that you need to get too far in the weeds about, because you should leave that, like Jim's scenario illustrates, to the local professionals that are familiar with that landscape, right? But it wouldn't hurt to have that knowledge ahead of time for your area, your likely scenarios. Again, this is why it goes beyond March. This is like an operational risk management type of thing.
Absolutely.
Consider these questions, right? Do the homework ahead of time before the emergency, so that you have a general idea of, okay, hey, did you know that it's going to take this long for any help to get to us, or this long to get to the nearest trauma center, and how can I mitigate those things?
Yeah.
Okay.
And maybe that means
questions.
I bring the trauma center to me. Maybe, I bring some surgeons out and I stage whole blood, and I do something about that, right? I buy down my risk somehow. Yeah. In general, for risk management, one of the big things with medical stuff, I want you to think about time. And time is complicated when it comes to this sort of thing, right? How long is a typical gunfight? Well, you can go on YouTube and see most gunfights are like, 17 seconds long or something like that. They're very fast. Some gunfights are like 6 hours long. So you've got how long a typical fight's going to go and how long it could go. Same thing with medical support. Normally, in the United States, how long are you going to have to be on your own before dedicated medical support gets there? Usually not long. You were talking like 10, 15 minutes, maybe. Worst case scenario, how long might you have to wait? And then we're talking hours. If we're talking disasters, we might be talking days or weeks. If we're talking like those big black swan disasters that the preppers are prepping for, we're talking like months or years. And your preparation needs to be realistic and balanced between what's the most likely scenario and what's the most dangerous scenario.
And as far as time being complicated, the typical gunfight, how long is that? How long you're going to have to normally wait versus how long could you have to wait for in your planning process? Let's say that your plan is, the nearest fight, I live across the street from the fire station. I'm just going to jam them over to the fire station. Well, what if they're out on a call right now? So you have this well-executed plan to throw this guy in the back of your pickup truck to drive him off the farm across the street or down the road, across the river, whatever, to the local fire station. You knock on the door and there's no answer because they're out on another call. They're taking, Aunt Susie fell and they're driving her across town to her insurance preferred healthcare provider location for, a hip x-ray or whatever. And now you're standing there banging on the door, wondering why your help isn't there. Is that a question you've asked yourself? You should ask that first, right? You should consider that possibility before the emergency. So other questions to ask yourself. I mentioned the football field thing. Are there intermediate points of care that are closer? So it might be a fire station, and maybe there's a fire station between you and the hospital that you can get on the phone and start to coordinate, hey, can these guys meet us at the front door? Or can these guys meet us at the parking lot? Or if you think you need a helicopter, that football field that you know about or whatever. Are there intercept points between you and them that you have to consider? Now, for most urban settings, you probably don't need to do that. You can probably just bring those people to you. But is it a question worth asking? And should you have an idea in your mind what the answers to that might be? Absolutely. How can you direct those resources to you? I did a range safety class for a group of people a little while back, and the range that they work on is in a weird place. It's like this property exists on like the edge of a landfill, and to try to call 911 and say our address is X is not really helpful because it takes them to like the front entrance of the landfill, and they need to go, down the road and around the bend to the open gate to make a right and it's complicated.
Turn left at the brown cow, not the brown cow facing east. You need to turn left at the brown cow facing west.
Mm-hmm.
It's very important. Yeah.
Right. And so how are you going to get those resources to you? Should you go to them? Should you send a runner? Maybe you got to send someone to go intercept them and guide them in? How are you going to communicate with them? Is that something you can get on the phone with them over? Do you have a radio or something to communicate with? Those are all questions that you should ask yourself. And then all of that should also drive what kind of supplies and what level of expertise you have. So if you know that you're going to be in a rural setting where you're going to be distant from any help, probably need more capability. If you know that generally speaking, you can have help in 10 minutes or less, you can probably curb that a little bit. But these are all questions that you should ask before you actually get to the patient assessment drama.
Okay, so you're out there at this shooting range at the landfill, and your buddy has a negligent discharge, and he shoots himself in the thigh, because that's never happened at a shooting range.
Mm-hmm.
Okay, so what do? Mike, let's do some first aid stuff for this guy. What do we do?
For first aid stuff. So, as I mentioned earlier...
Slap a Band-Aid on him, tell him to rub some dirt in it.
Yep, well, and my gripe is with a lot of the training nowadays is everyone's like, yeah, I'm pretty tactical now because I carry my cat tourniquet everywhere I go, or my soft T wide. I got my tourniquet. I carry that everywhere I go, and so therefore I am prepared.
My everyday carry.
Yep, my EDC. And so here's the thing. March. We're going to get into March and what it stands for in a second, but before you get to March, you're starting with a scene size up. You're walking up to this situation as it's unfolding in front of you. There you were. It was a dark and stormy night, and you're starting to make an assessment. It happens then, right? These are the questions that you need to ask. Is this scene safe? And I know we kind of joked about it a little bit earlier about, like scene safety, it's all relative and all these things. Making the scene safe is a component, but it's also about not making more casualties, right? And so the big question here is, what caused this injury? Mechanism of injury. Are there downed power lines? If this was a car accident, if it was an active shooter or active killer, is that person still in the area? Are they around? Are there explosive devices that they might have laid for us? If it was a car accident, is anything on fire? Are there fluids leaking? Is something going to blow up? Right? These are all considerations as you walk up to this person that needs your help. Part of your scene safety, right? How many people am I talking about? Is it a car full of, the bus full of nuns that flipped over on the freeway? I've got 38 patients, women and children that are all bleeding out. Or do I got one guy on a motorcycle that got, schmucked by a semi? If there's stuff that I'm going to need, what is it? So if I notice that there's a shitload of patients, that's a technical term, a shitload, right? Do I need to start calling for more ambulances and more people? Do I need more supplies? You want to start taking those counts in your head. Are people trapped, right? Car accidents, this is a big one. A need for extrication is something that in your 911 call, you might want to communicate that this car is not only upside down, but there's people trapped inside. So make sure you send the guys that got the jaws of life and all the tools to cut people out of cars. And there's some exotic ones too. Like that one's pretty standard. You'll get that in your 911 questioning. But let's say, for example, a building collapsed. That's a specific area of expertise that you got to report on the phone so they can let the people know that you're going to have to send your building collapse people, that there's some special equipment involved there. Or things like high angle rescue. Are they down like a big embankment or in a trench? Those are things that are factors. The easy way to remember all of those questions is an algorithm called Penman. Back in EMT land, that's what we talked about. And that was personal safety, environmental hazards, power lines and fire and ice and water, and those things are all environmental hazards. Number of patients, mechanism of injury or nature of the illness, need for additional resources, and need for extrication. But more simply put, what I want you to take away from this is as you're approaching this person, there's a lot of information available, and some of that information needs to be communicated to get to that end state that we talked about. Yeah. And what is that again? Bright lights and cold steel, getting this person to definitive care, which is an important part of the process. It doesn't end with the application of a tourniquet. It's part of that big picture.
So
right?
Mindset-wise, you're always bouncing between forest and trees and forest again, right? Big picture, little picture, big picture, little picture. Okay, so I've looked around, I've looked behind me, the thread is down, the car's probably not on fire, whatever, right? I got to look at the person. How many people do I have? Have I accounted for everyone? If my house catches fire, one of the very first things I'm going to do is make sure I have all the humans accounted for, right? Get a count, and then get an assessment of what I've got. That gets into triage, and triage is probably a different episode, but you need to have a sense of how bad is everybody hurt, and work one person at a time, start assessing through that individual person. And one big assessment thing is a term called gestalt, which is like their overall appearance. Are they overall turning blue? Are they overall missing a limb? Right? Big picture and then go little picture. What's the obvious problem with them? They're bleeding out. What's the less obvious problem? Maybe a head injury that you don't see or a neck injury that you don't see, right? So what's the obvious problem? What's the hidden problem? And keep looking for a hidden problem. Keep looking for the +1, right? We've talked about that in other episodes. The screamer, the person sitting there hysterical, probably not the most hurt. And also neither is the person who can walk to you. This is a big parenting tip. Every time my kid gets really, really hurt, the very first thing I say is stand up and walk to me. And that gives me a lot of little assessment things, right? I can tell if they can't stand up, that's probably a sign. I can tell if they walk to me weird, that's a sign, right? And if they're up and walking, maybe I can use them. Maybe I can say, okay, you're up and moving. I need you to help me with this scene. Put pressure here, right?
Yeah. Well, and following commands, following instructions is
they
an important
tuned in?
like mental status. So the way that we word that in the medical realm is a general impression, which speaks exactly to what Jim is talking about, making a general impression of your patient as you're approaching. And you can see, is the person like awake, alert? Are they talking? Are they just moaning in pain? Are they unresponsive? Will they respond if you call out to them? Will they respond if you try to shake them, or if you start, trying to move them or something? Are they going to respond to that? Those are all good indicators of the general status of the person, which is an important first step in your assessment. So when we talk about March, you have to understand that as a learning tool or a teaching tool or a patient assessment tool, even in practice, this is a global assessment. We're trying to simplify a situation, a scenario. We're not saying that first you shall do this, second you shall do this, right? We're giving you a list of things to consider, and in approximately that order. But what we're looking for are things that are going to kill the person and things that we can do about that, right?
An analogy here, think of it a little bit like driving, right? Your speed matters, right? You occasionally, hopefully, look at your speedometer. A bunch of other things also matter. Are you going to run into the car in front of you? Are you going to look into the car behind you, right? You got to keep kind of moving your eyes around and have a global picture around you of who's left of me, who's right of me, who's ahead of me, who's behind me, how fast am I going, what am I approaching, do I see brake lights ahead of me, right? You have to do all of those things. And if you're just staring at one thing, or you're just going in sequence, look ahead of me, look behind me, look left, look right, you're going to miss something. If you get too robotic with this stuff, it gets silly really fast.
Yep. So in general, in a not robotic way, speaking of, which is, I think, a good way to put it, because again, this is a global assessment. If you get out of order, it's generally okay, as long as you don't neglect the other areas, right? So massive bleeding or massive hemorrhage, the M in March. First thing that will generally catch your attention is the bright red spurting blood going across the room from some area, an extremity generally, or a junctional area. If it's in the torso, a lot of times it's going to be internal. You might not see a lot of external blood. I'll come back to that in a minute. But massive bleeding should command your attention. The general ways, and this is not a skills class. I can't teach you in a podcast like how to apply a tourniquet or how to pack a wound. You're going to, but you can literally Google that. There's YouTube videos on it. Just make sure you're watching from a informed source. Google TCCC and actually go to like Deployed Medicine. I want to say it's deployedmedicine.com or something like that. But like the guys that write TCCC and train that for the military, they've got their protocols and guidelines and everything on the internet for free. It doesn't cost anything. You can at least read up on it. You can watch some YouTube videos, but make sure that it's not like Uncle Joe, teaching you from the shed, right? Wound packing and tourniquets are generally the ways that you're going to manage external bleeding. Now, my caveat here is, what do we mean by external massive bleeding? And I see a lot of people that, you got what it looks like there is you got a gunshot wound to your forearm, so obviously I should apply a tourniquet. If it's not bleeding
that's what that
bad,
cartoon says, right?
Right. Pack tourniquet the extremities, pack the junctions, seal the box, right? Look, if it's not bleeding that bad, you can probably fix it with like direct pressure and maybe like some gauze or a t-shirt or a towel. You don't necessarily need a tourniquet. What does a tourniquet get you? If you're in a tactical setting and you're getting shot at, I'm going to go to my most effective, my most foolproof option, which may very well be a tourniquet. That's if it's bleeding a lot, though. And so what is a lot? You got to look for that. Bright red spurting blood, arterial bleeding. Again, Google that shit. You can look at a YouTube video of a pig with a femoral artery bleed and see what that looks like. Those are generally worthy of a tourniquet, but control it one way or the other. Your general options there are tourniquets for the extremities, wound packing in the junctional areas, the groin and the armpits. But I will tell you that for most bleeding, direct pressure and tight dressings will manage it. Okay? So, massive bleeding, do what you can to control those. And if that commands almost all of your attention at the time, then that's good. Because if someone is hemorrhaging, arterial bleeding, they're on a pretty short clock before that becomes problematic.
That's why the M comes first, right?
Right.
If they're bleeding out, they're going to bleed out pretty quick, and that's the game.
Now, in that scene size up, when we talked about mechanism of injury, this is where we also have to consider, is there potentially internal bleeding happening that I can't see? If the guy got shot in the abdomen, what kind of gun was it? Did the bullet exit the other side? All of these things. And you can kind of see just from an anatomy standpoint, like, hey, this went through like his butt cheek. All right, that's pretty like meaty tissue. I'm not terribly worried about a butt cheek. If it went through his chest or his abdomen, there's a lot of vital structures in there and a lot of vasculature that it's a pretty good possibility that hit something important. So even though there's no massive bleeding that I can do anything about personally right this minute, my index of suspicion for internal bleeding is pretty high. I don't get that from tourniquet the extremities, pack the junction, seal the box. I get that from looking at the whole situation, right? Moving into airway, the A in March is for airway. For most bystander, citizen, off-duty, everyday carry types of people, there's not a whole lot that you're going to be able to do for airway problems. The biggest thing is just to take a note if it's open and clear, if they're able to breathe okay, and if there's anything obstructing their airway. The most common things in trauma, first of all, are going to be the tongue. And if not the tongue, then things like blood or vomit, right? And if those things are a factor, the most effective thing that most people can do is just position them in a way that their tongue will fall naturally. You can do like a head tilt chin lift or jaw thrust maneuver. There's some caveats with that we won't get into in this episode, but positioning their airway in a way if they're unresponsive. But probably the biggest one, if they're bleeding a lot or they're vomiting, is to just sit them upright or turn them in a way that gravity will help clear their mouth and nose of that stuff so that they can breathe.
Yeah, if there's an obvious obstruction, do something about the obvious obstruction. That's the long and short about it. No air, no live.
Right. And if you're trained to use any other adjuncts like an oral or nasal airway or something like that, then go ahead and use it, but only if you're trained for it. Okay, outside of the scope of what this podcast is going to be able to cover. The R in March, so we've covered massive bleeding, airway. Now we're at R, which stands for respiration. And if you talk about ABCs, airway, breathing, circulation, the B kind of covers the respiration thing. The people who want to talk in technical terms will say that respiration, the difference there is we're actually talking about the exchange of oxygen either in the lungs or at the cellular level. And that is true. But just for the
it doesn't make for a good acronym to say inspiration, so you have to say respiration. Nerds,
right? And so you have inspiration and then respiration being the exchange and whatever. I mean, you can nerd out about this all day long, but focus on the breathing part. That's what we're after. Notably, how well are they breathing? Are they breathing really fast and shallow? Are they breathing really slow? Do you hear anything like it sounds like they're snoring? Snoring respirations are not a good sign. A lot of times it has to do with injuries where that tongue will relax and get in the way of their airway. But status is probably the biggest thing to take note on.
And are they really asymmetrical, right? Is one side of their chest moving and the other one not? That sort of thing.
Yep. Now, if they have any chest wounds or wounds to the torso that you can intervene on, you can talk about things like chest seals, like if they have a gunshot wound or a stabbing or any kind of open chest wound between basically the level of their neck down to about their navel. You can consider things like vented chest seals. But again, what I typically care about the most when I'm first making this assessment is, are they breathing and how well are they breathing? In other words, am I going to have to help them breathe at some point soon? Okay. C for circulation. Again, status. So pulses, you'll have to look online for videos of and diagrams of where exactly you can find a radial or carotid pulse. In other words, a pulse at the wrist or the neck. Number one, I care that they have one, right? Do they have a pulse? And if they're alert and they're talking to you, we can assume that, yes, they do. And number two, I'm looking for changes in their pulse. So is it really fast and weak, or is it at what I would call a normal rate of 60 to 100-ish? And does it feel pretty strong? Now, that's not something, again, that I can teach you how to do in a podcast. What you can do is friends and family, you can practice checking pulses and you can see what normal feels like. And then you can look for things that are abnormal. Another important indicator when it comes to circulation, and when we say circulation, we're talking about the movement of blood with oxygen to the cells. You breathe in, your lungs transfer oxygen to your blood, and that blood is circulated throughout your body by your heart. And so when you're feeling for a pulse, you're feeling that blood circulate through those areas, right? And if they don't have a pulse, then they need CPR to artificially circulate blood. But for a person who was just a victim of trauma of some form and you're trying to look at their status, one of the really good indicators for someone who's otherwise alert and conscious is their skin. And what I'm looking for, we had a saying where I used to work that skins don't lie. And I think most EMS, paramedic EMT type providers will have a saying similar to that the skin signs don't lie. And I'm looking for skin temperature, moisture, and color. So normal, warm would be like normal skin tone, normal skin moisture, and it feels warm to the touch. If it's pale, cool, diaphoretic, hot, flushed, and dry, those things all kind of stand out. But color, temperature, and moisture level are things that I might look for in someone's skin signs. If I've controlled all of the bleeding that I can see and someone is pale, cool, and clammy, that's a red flag. And I want to try to explain that, right? Now, there's times where if this person was just in some kind of fight and they were running from point A to B and the weather is whatever the weather is because the weather outside is weather, I have to factor that into looking at skin signs. But generally speaking, if someone is pale, cool, and diaphoretic or clammy, they feel real moist to the touch, that should stand out as like a really bad indicator of their status, especially if there's the potential for injuries that I haven't seen. So internal bleeding, whether it was from like a fall or a car accident, or if there was potentially a bullet hole or a stab wound that I haven't found yet. Head and hypothermia. So we've covered MAR and C. We're now at the H. Now there's kind of two H's. Head is to address the head injuries and the potential for spinal injuries, and also to assess the person's mental status. We won't go in the weeds here, other than to say that it's a good idea, generally speaking, to talk to the person, know what their state of mind is, and people always love to help with this. If, let's say, for example, Jim was in a bad car accident.
Motherfucker.
Hypothetically. And I walk up to Jim and I'm like, hey, buddy, tell me your name. And like Jim's, I don't know, neighbor is like, his name is Jim. And I'm like, yeah, thanks, asshole. I'm not asking you. Like, I know Jim's name. I'm asking Jim to see if he knows his own gosh darn name. Right?
Bless their hearts. They're so helpful.
Yeah. And so, hey, can you tell me how old you are? Oh, he's 36. Okay, great. Thanks. I'm not asking you, guy. Can you just... So people love to help with this, but really asking those questions, it seems kind of silly, but you're trying to get a baseline of like, if they start to get confused and those things and they're not able to tell you what happened to them or where they are or what day it is. And again, for some people, maybe that's their baseline, but it is important to note in the beginning what that baseline is and then look for changes, monitor changes, right?
A couple things on that real quick. Having had a head injury, it was a lot of fun. Raise their head up a little bit, get them in kind of a reclined position just to take some of the pressure off, is one of the things I've been taught. I also have a friend who had a major spinal injury. Here's the deal. I was always taught in first aid, if there's any possibility of a spinal injury, you don't touch them, you don't look at them, you don't move them. Generally speaking, that's true. However, this guy had a spinal injury. He was head down, feet up, underwater. They had to move him. It was what it was. I don't think they actually made it any worse, but it just happened that the people who were with him did an incredible job stabilizing his neck and saved his life. In a TCCC situation, one of the things that makes TCCC different is where we prioritize potential spinal injuries relative to other injuries. And one of the things that we have found is spinal injuries are rare enough and getting shot sucks bad enough that if someone's in the line of fire, you go ahead and move them out of the line of fire, right? Life over limb. And that's something that's easier. It's easy to say it in a classroom. It's easy to hear about it in I don't know, a TV show or a YouTube video. But you need to think about what that actually means. And it means something like this, right? they may not be real stable, and you might need to really drag them off the street. And this is where you get paid the big bucks to make a good decision, because it might affect whether they live or not, and it might affect whether they ever walk again or not. Welcome to the tactical world. Decisions have consequences.
And so when it comes to head injuries and spinal injuries in general, the best thing that I can tell you, because you do want to be aware of them, and if you're dealing with someone that fell from a great height or was in a very serious car accident,
mechanism of injury, right?
Or something where the likelihood of a spinal injury is high, then yes, go ahead and consider that there's a possibility that their spinal cord was compromised by something that might have been broken along the way, and that we don't want to do anything to aggravate or cause any further damage to the spinal cord. But that being said, at some point they're probably going to have to get moved, and especially when it comes to like Jim was talking about, in a tactical setting where, yeah, wouldn't it be great? And another example that, car accident. This car flipped over 58 times. Is the likelihood of a spinal injury pretty high? Yeah. But if the car is catching on fire, what's going to kill him first? Probably the car fire. I'm not going to sit there with a backboard and be all perfect about it. So you've got to take the lesser of evils. And the practice as it relates to managing spinal cord injuries or the potential for spinal cord injuries in pre-hospital settings has been changing quite a bit over the last 10 or 15 years, to the point that we're on a increasing level not using a lot of the backboards and collars and stuff. We're kind of just restricting their movement a little bit. And, I'm going to refer you to local guidance and practice on that, because that's not something I'm going to touch in this episode. But just consider it. Look at the mechanism of injury, consider the possibility that there could be a spinal cord injury, and be mindful of that if you have to move or manipulate the person in some way. So head injuries is kind of the prompt for that, because it's the big component of the central nervous system. Spinal injuries is sort of all encompassed by that. You need to at least consider it. Look at their mental status. And I said there's kind of two H's, because the second one is hypothermia. And this is important for two big reasons. The first is your body has a natural ability to stop bleeding to some extent, right? To clot injuries and reduce the amount of bleeding that it has. Your body's ability to do that is affected by the byproducts of hypothermia. And this brings me into the second reason that hypothermia is important, and that has to do with energy. So shock, if you've ever heard of he's in shock, it's not like the suspenseful, I was shocked by this. This has to do with inadequate perfusion or circulation of oxygen to the cells of the body. So your organs, your cells need oxygen to produce energy for their essential functions, right? To include your brain and all of your vital organs. That oxygen allows your cells to produce energy at a rate that is most efficient. And if your body is taxed for oxygen because of blood loss, for example, or an airway obstruction, for example, or something, there's a number of mechanisms here that can happen. With less oxygen or inadequate oxygen, your body starts to burn fuel differently, and it produces substantially less energy. And in a nutshell, that's part of the problem as it relates to energy consumption to perform those essential functions of your cells and organs, right? If you become hypothermic and you need to stay warm and you start shivering, what are you doing? You're burning that available energy. So Clotting factor and energy consumption are two important reasons that body temperature, maintaining an appropriate body temperature, are important in trauma care. So it doesn't mean that you need to like make them, boil their blood or whatever. But if you are a normal functioning person taking care of a trauma patient, you should be uncomfortably warm. Okay. So blankets, warm environments, and making sure that wet clothing is removed and replaced with dry are all things that you can consider in terms of effective trauma care for preventing hypothermia in trauma.
And this is a good opportunity to point out empathy. Just put yourself in the shoes of that person and understand when you cut all their clothes off, you're going to make them colder. And cutting all their clothes off is like a fairly standard thing to do in first aid. First thing they do, they lose their pants. It's one of those things. Also, when they're getting transported, if they're in the back of a pickup truck or in the back of a helicopter, it's going to get real cold real quick, especially if they're lying down against metal, that sort of thing. So a little empathy will help a lot. And speaking of the empathy, one thing that I think is worth talking about here is talking to them. Talking to them in general, one, helps you assess them. We already talked about that a little bit, like what's your name, what's your favorite color, what's your computer password, but also
mother's maiden name.
Understand they're scared, they're relying on you, they're trying to read you to figure out how serious their situation is. Them panicking isn't going to help anything. You need to be cool, calm, and collected. You need to bring some calm to the storm. And you need to be the guy you need to be Captain America, right? You need to say, hey man, I've got you. You're going to be okay. We're going to get through this. You're a little banged up. That's okay. Help's on the way and I'm part of it, right? You got to be Captain America a little bit.
Mm-hmm. And I think, part of the head thing, mental status, one of the important signs actually is things like repetitive questioning or repetitive statements. If they're saying the same things over and over and over, it's a good thing to take note of. But where you tend to really pick up on that stuff is in just communicating with the person. Hey man, talk to me. How you doing? Do what you can to reduce their anxiety. And I think that speaks well to what Jim is talking about. So that's March. Massive bleeding, airway, respiration, circulation, head, and hypothermia. So it's March, right? There's two H's there. And I've even seen where people have added an E or two at the end. So it's March E. And so this can go, like, we can go on for days, right? Like, we can be like, march around the parade grounds for all day until your legs fall off. And every single one of those letters stands for something, including the last part of that. March E. E is everything else. And where this comes into is, okay, you get through your like massive bleeding, you threw on a tourniquet, you look for internal bleeding possibility, their airway is intact, they're breathing okay, you've positioned them well, you took a pulse, their skin signs look how they look, their mental status is what it is, you put a blanket over them to prevent hypothermia. What am I missing? And this is where you start maybe cutting clothes and looking for other injuries. Now, in terms of cutting clothes in tactical settings, there might be, you're in that indirect threat care where this is a warm environment. We haven't made the scene totally safe, but it's relatively safe for the time being that we can start going through these things. Do I want to remove that person's body armor? Maybe they're going to need it still, right? So you have to be thoughtful about those things. But at some point, when you get to that cool zone where you've made everything safe and it's appropriate to do so, you need to start looking for other injuries and looking for anything else that you might have missed. So E is for everything else, and it accounts for even things like looking at their medical history, allergies, medications, things like that.
And you need to feel around them a little bit. One of the kind of funny tactical isms of the last 10, 15 years was black latex gloves became really, really popular because they look cool.
Oh my God.
They were tactical, right? And we discovered that, especially in bad lighting, blood against a black glove doesn't look like anything. So maybe like tan or maybe blue gloves, like what you'd see in a hospital setting, are worth doing. But feel around, look for malformations, disformation, holes that shouldn't be there. You got to feel around a little bit.
Yeah, and one of the ways that you do this is with like a wound sweep. So we talk about raking or sweeping for wounds or some combination thereof. Again, YouTube, you can look for wound sweep, wound rake. There's a kind of blended technique there for doing a quick, rapid head-to-toe assessment, looking for other injuries and things that you can treat. But the idea there is, again, if you're looking at this from maybe not 30,000 feet, but maybe like the 5,000 feet off the ground, you did your scene size up, you saw how serious does this look, what are the number of people I'm dealing with, what are the environmental hazards that I'm looking at, what's the mechanism of injury, and then you're kind of going into that general impression. How bad does this really look? There's no massive bleeding. Is there anywhere he could be bleeding from? You're going through your airway, respiration, circulation, head, hypothermia. Okay, what am I missing? And this is where you start doing that head to toe. And maybe that involves cutting clothes off or maybe not, but you're looking for the stuff that you're missing. And there's the potential for that second E if you wanted to go into the March EE, and that's for environmental stuff. And so you can look at the sorts of things like if you're in a super hot or cold environment, correcting that. If you're in an unsafe environment, correcting that. Those sorts of things. But again, you probably should have accounted for that already at that point.
A couple things you want to think about real quick. If the guy's armed, should he stay armed?
Yep.
What's his mental status? Is it a good idea to keep him armed, or is it a good idea to take his weapons away? Does he have explosives on him or inside of him? In a combat zone, that's a thing. And is there anything else we need to get off of that person before they go out of our control into another level of care? Do they have encrypted radios, that sort of thing, or classified materials on them? Right? It sounds silly, but like those are the types of things, especially as a leader in that environment, you need to be like, nope, let's go ahead and pull the night vision off of them. Because either we're going to need it, or that's not something we want out of our control.
And that brings up actually another good point. And those are all, I agree with all of that. But if you are still tactical, right? Direct threat care, indirect threat care, especially. Some things you need to look at are part of your scene size up when you say, hey, is this something that I can reasonably intervene with that isn't going to make the problem worse? And there was a incident in Philadelphia, or it might have been Pittsburgh, I can't remember, I'll have to look it up, where this dude like shot a cop, and then some cop went in to rescue him, and he shot another cop, and then another cop went in to rescue them, and he shot another cop. And this has happened in, different scenarios overseas a number of times where they're using those casualties to just bring in more targets, and people become additional casualties. And does that make the rescue effort better or worse? Way worse. So, yeah, we all want to intervene and go help the guy, but we got to ask ourselves if, a dead rescuer is not an effective rescuer, right? So are we going to make the problem worse by doing so? And how can I make it better? Maybe that means from a distance, I can do a remote assessment and say, is that guy even viable? Like, quite frankly, that's part of the sober conversation that you need to have is, does that guy look like it's worth the risk to go and get him? And that's going to be a hard call to make if it's one of your buddies, but it's a conversation you need to have. If he's viable, is he able to follow any instructions? Hey man, can you move to cover? Hey, there's a giant rock about 30 feet to the east of you. Can you crawl to that? Or can you crawl to me? If I throw you a tourniquet, can you put it on? Do you have a tourniquet on you? Right? So there's some remote assessment stuff and remote treatment stuff that you can do. That also plays into what you can do for yourself if you are injured or wounded. You should also be thinking about those things. So again, part of your scene size up has to include that remote assessment, remote treatment, and self-aid. And another component there is if you do have a guy who is mostly with it and you think is still capable of keeping his equipment and stuff, give him a job, right? Give him a job to deal with all the dread and anxiety that he's dealing with while you're working on him, if necessary, if he can't treat himself, right? Hey, man, can you watch this corner for me? Cover this area for me. Let me know if anything pops up over there. Give him something to do, right? Moving on to some of the injuries and interventions that you might see. And again, we're blazing through some of this because, this in an audio format, I can't show you pictures or diagrams. I can't draw stuff for you.
But we can help you get a
research.
sense of things that you may not be proficient on and may help motivate you to go get proficient on these things. That's our goal with this, is introduce a whole bunch of topics, get you thinking about it, get the words familiar to you, and then motivate you to go get into it.
Yep. So we've talked about the basic gripe that I have with the infographic that just oversimplifies things a little bit, right? And Jim also talked about like multiple patients and mass casualty stuff, and I agree with him in that that's a whole different episode that we can get into another time in terms of how to manage that. But you do have to consider that if you get too bogged down dealing with one guy who you think is the worst patient, you might potentially let other people suffer and not get the help that they need because you're stuck with that, right? But let's say that you've approached your one guy that needs your help and you're looking at this March thing, massive bleeding, airway respiration. Back in the day, I was taught this saying that I still remember: a cow open fired today, holy shit. And it was either holy shit or holy smokes if you wanted like a G-rated version of it, but a cow opened fire today, holy shit. And what it stood for was A, airway obstruction, C, cardiac arrest, O for open was open pneumothorax, fire or F was for flail chest, today or T was for tension pneumothorax, which is separated from open pneumothorax a little bit earlier, H for hemorrhage, and S for shock. A cow opened fire today, holy shit. So this memory device, they call it like the 7 major life threats. They're not the only 7. It's not an all-inclusive list, and I don't even know that I'd call it the best 7, but it's a good starting point as a primer, like introduction here. That's why I'm using it. So airway obstruction. Now, again, just kind of blasting through these things. We talked about the basics, right? The tongue is the most common airway obstruction in trauma. You can generally fix that by positioning. You can also deal with things like blood and vomit, which the best way to deal with is usually using gravity to your advantage. So position them in a way that that stuff will drain out, and so they can breathe through their mouth and nose. Anything more than that is going to require tools that you need training for. And so if you have that, then use it. But anyone that doesn't have it, we're not going to be able to teach in this episode. Cardiac arrest, that's a CPR situation. And in trauma cases, I can tell you that someone who has no pulse and is not breathing after trauma, their odds of survival are pretty low. But CPR is basically the intervention there, with the caveat that you still potentially have airway and bleeding problems that you need to deal with. Pneumothorax. So this comes up twice in this list of 7 life threats: open pneumothorax and tension pneumothorax. Pneumothorax is a really fancy term for air in the pleural space or in the lung cavity. So the
air in your
area,
chest, but not inside your lungs.
Right, the area inside your chest where your lungs are contained. If air gets in there, which affects your lungs' ability to expand to their fullest, right? And so if enough air gets in there, your lungs can start to collapse. So an open pneumothorax would suggest that there is an intrusion from the outside into your chest. So a gunshot wound or a stab wound. People talk about this as like a sucking chest wound, which isn't typically how you see that. But an open pneumothorax means that there is some kind of hole from the outside, that air has gotten into that space between your chest wall and your lungs, and it's affecting your lungs' ability to expand. And so when we say chest seals, when you hear about vented chest seals, what we're talking about is putting basically a barrier over that hole to prevent air from getting in, to try to mitigate that. Now, this is an area of contention because let's say you have someone who got shot in the chest and that hole has gone through their chest and into their lung. There's a potential that when you put a seal over that, you're also going to trap any air in there that might have otherwise escaped. And if the lung is also, if there's an ability for air to come in from the lungs, if that's also been damaged, you can create some problems there. So at a basic first aid level, for example, American Heart Association, if I'm teaching a first aid class through them, they don't recommend chest seals. And the reason is, if you put a chest seal on the person and air is continuing to get into that space and you trap it there, you can make the problem worse. Now, people who have training with chest seals are taught, put the chest seal on, and if that starts to become a problem, you take it off. But that assumes that you're going to monitor your patient and stay up on that.
And so, just to be clear, my understanding from our discussion with Dr. Tang is these pneumothorax considerations typically don't present real fast. Yeah. And this is one of the things where you're sitting waiting for the helicopter to get there, it ain't coming. Right? So this is where I talked about, how timing is weird. This is okay, well, we have this magical golden hour, we got to get the guy to hospital, and for whatever reason, it's going to be more than that. Or, I'm just sitting waiting because the time I spend sealing a chest, generally speaking, is probably better spent putting the guy in the back of the truck and starting, trucking toward the hospital. So this is where you have to kind of balance those things and work that mindset, the problem-solving mindset of this guy's got, his problems are getting worse, and I don't have him in bright lights and cold steel. What am I going to do about it? Am I going to try and dial down how bad his problem is, or am I going to try and dial up his evacuation?
And it also assumes things like in a combat setting where this guy is maybe 2 hours from help,
from anything,
that I'm trying to buy as much time as I can, but he's also going to be under like the constant supervision. He's going to be monitored all the way in. And so if things change and I need to take that chest seal off, I can do it. Again, from a legal standpoint and from an acceptance that we can't teach you everything in this format, I'm not going to give you any advice about chest seals. Whether you should, whether you shouldn't, you're going to have to make your own grown-up decisions about that. I'm not saying they don't serve a purpose. They definitely have their place. But I will say that there are some people and sources out there that caution against them on some level. So just there's a pro and a con there, a trade-off, if you will. Okay. A cow open pneumothorax, fire, F, flail chest segments. This has to do basically with ribs that are broken in multiple places. So Jim mentioned earlier, if you're looking at their breathing, you're looking for equal chest rise and fall, and you happen to see that part of their chest isn't expanding with the rest of it. And that's called paradoxical movement. You can actually see it almost like go inward instead of out, instead of expanding. It kind of like vacuums in a little bit. These flail chest segments are multiple ribs broken in multiple places. There's not a whole lot that you can do for it in the field, but what most people will get some relief from, because it can affect their ability to breathe effectively, is by taking like a blanket or a pillow or something and holding it to their chest to kind of splint those segments from moving so much on breathing. It causes a lot of pain, and the potential is there with those like loose broken bones that you can potentially get a pneumothorax. You can puncture a lung or something and cause that. So splinting is the best thing that you can do for it. But other than that, again, definitive care. Today, T, tension pneumothorax. Now, air getting into that chest cavity outside of the lungs is a problem because the lungs don't fully expand. If enough air collects in there and the lungs are really restricted from expanding because of the increasing pressure or tension, it can actually start to put enough tension on the internal structures of the chest, i.e., your heart and the vessels leading to and from your heart, that it can cause circulation problems, right? That your heart doesn't pump as effectively, and that those vessels carrying the blood are restricted, and so you're not getting as much output. That's life-threatening. You can have a pneumothorax that is not a tension pneumothorax, but if those things start to progress, those are the circumstances where you would do things like needle decompression if you were trained for it. For the layperson who is not trained for it, all you can really do is recognize the potential for a tension pneumothorax. If they have a chest seal over a wound that they're breathing, they're having more and more trouble breathing, you might consider taking it off. And beyond that, there's not a whole lot you can do for it unless you're trained how to do chest tubes or needle decompression. So bright lights and cold steel is a solution there. And so I'm not going to get too far in the weeds on that one. Hemorrhage, that's our massive bleeding. So we talked about wound packing and tourniquets. I would just add that you can have brain hemorrhages. You can have internal bleeding in the torso that can also be life-threatening. So just because you can't see it doesn't mean that they're not hemorrhaging somewhere. And shock. So we talked about shock, and that can be for a number of reasons. The most common, or the one we think of most often in trauma, is a loss of blood, which causes inadequate perfusion of oxygen throughout the body. The way that you fix that is generally with like blood transfusions, and you guessed it, going to the hospital.
Yeah, and just I want to reiterate, because you hear it in movies, you see it in TV shows, someone saying, you're in shock right now. We're not talking about that. We're talking about someone's body shutting down because of trauma.
Yeah. An inability of the function to sustain life is impaired. And that has a lot to do, again, with like getting oxygen to the cells. And so stopping bleeding can reduce the complications of shock because you're keeping as much blood in the container as possible, right? Making sure that you can get an adequate amount of oxygen is a big deal.
Air goes in and out, blood goes round and round. That's how it's supposed to go.
We're all happy. Yep.
Yeah.
So what else? Basic injuries and interventions. I mean, the big question here is trying to understand what's going to kill the person. And that takes an understanding of like basic anatomy and physiology. These 7 life threats that I talked about is just, again, an introduction to it. But it takes an element of critical thinking and problem solving to try to figure out what's going to kill this person, doing a good head to toe assessment and looking for things that maybe you didn't notice, and trying to figure out how sick this person is and what you can do to bridge the gap between you and definitive care. Your best intervention in most cases is, we used to say when I worked on the ambulances, a diesel bolus. A bolus is just like a rapid infusion of like fluid. And like we would just say diesel, right? They need to get to the hospital. That's the kind of the key. It doesn't mean there's not life-saving interventions you can do, but it should always be in the forefront of your mind in terms of objectives.
And this is one of those forest and trees things, right? Like we're talking, we're mentioning some of the more complicated things so that when you need to make them simple, you can make them simple. We're also talking about those oversimplifications, the, tourniquet the extremities, packs the junction, seal the box thing. That's simple, but then we need you to understand a couple layers past that so you understand when that's appropriate and when it's not.
We're going to blast through some supply stuff as far as the equipment goes, because there's lots of equipment choices out there, and there's a lot of pre-made kits out there. I've never had great luck with any pre-made kit that I've ever bought, with very few exceptions. There's some super simple, basic trauma kits that you can buy from like TACMed Solutions or North American Rescue that have all good stuff. But a lot of the stuff that people like put together, I don't know. I've just never had great luck with it. I've always found that putting it together myself is a little bit better. And the reason for that is I'm putting my equipment together in the context of my own skill and my own environment, my own situations that I'm likely to find myself in. When I go on a road trip, like if I'm driving to Vegas to SHOT Show, I'll bring like my medic bag, like my rucksack with all my crap in it. And this is important. Like if you're packing a quote unquote rucksack or a backpack full of stuff, do you want more of the same? Do you want a capacity to treat more people for bigger types of emergencies?
So you keep a tourniquet strapped to your ankle 24/7, 365, but instead you have like 10 tourniquets in your backpack, right?
Yeah, for the Vegas shooting per se, right? Now, a lot of the reason that I'm packing that backpack is because I'm going on a road trip and I'm going to be driving through areas where I might not have cell service.
There's only the hill people and the aliens out there.
Or I'm driving through areas that even if I have cell service, help is going to be 20, 30, 45 minutes, an hour, or maybe more away. Mm-hmm. And so I'm trying to afford myself those things. And I'm also looking at the types of emergencies I'm going to face. So probably a car accident in those places. And if it's going to be a car accident, I'm looking at maybe the potential for mass casualty incidents. So I do want more supplies, but I'm also looking at capability. So whenever I take my medic bag on a road trip and I'm thinking about that sort of thing, I may be also bringing like not just rubber gloves, but like work gloves for working around sharp edges and other types of hazards. And I'm bringing like a headlight. We talked about the lighting thing Jim brought up earlier. And so you're also looking at more capability, not just more products or more supplies, but also more capability. And that obviously depends a lot on the amount of skill that you have and who it is that you're hoping to take care of. I'm the type of person that if I happen across a car accident and it's random people, I'm probably going to try to help them. That might not be you.
Yeah, and there's context here, right? Mike was a professional EMT for years. He's a current and qualified medic in a law enforcement capacity. There's a lot he's going to be able to do that a typical person who doesn't have that background won't be able to do, and that's okay. My thing about packing up a backpack is you tailor to your level of training, know your limitations. You don't have to go full rescue Ricky. And it's easy to do when people start getting a little training, they start to way over assess what they can and should have. And, you know, we're gear guys. I have gear. Mike has gear. Just know your limitations and understand it's less about the tools and more about what you can do with them. And
you got to remember, People Ideas Hardware, like it wouldn't be a Tac Tangents episode if we didn't say People Ideas Hardware.
Oodle loop.
And, you are the weapon here, so to speak, right?
God.
So your own problem solving and decision making, yes, there's life-saving equipment, no doubt. Like if you need a tourniquet, you should have a tourniquet. You shouldn't be improvising one out of a flashlight and a belt. That's stupid when tourniquets are so readily available in this day and age. But you are the most valuable tool on that scene at that time. So plan accordingly. So you've got like your individual first aid kit level, which is the sort of thing that you can carry on your person wherever you're going to be. If you're going to, let's say, SHOT Show, and you're going to carry stuff in a backpack, right? You're carrying that with you. Then you've got like your basic, maybe some chest seals, your quick clot, combat gauze for wound packing, a tourniquet or two, and some airway stuff if you're trained and capable for it. That's different than like the rucksack level, because if you leave it in your car and the building collapses, it doesn't do you a lot of good if it's separated from you physically, right? So you have to just look at, what is my environment going to be? How much am I going to have with me? And then gear it accordingly. The one caution that I want to give
real quick on that, what that drives me toward, and I suggest it for you, is probably 3 kits. You probably need a kit in your house. You probably need a kit in your car that's going to move with you. And you probably need a kit at your office or your school, right? Because it doesn't do any good far away from you, or in a closet, or in a garage, or in a storage room. This is the stuff you're going to need for the 10 to 15 minutes until the ambulance gets there.
Yep, that's true. And there's, you can look at a ton of different kits online to see what's in them and what might be useful. One thing you might want to look at is things that are only built for one task versus things that can multitask. If you find yourself holding a tool that can only be used for one purpose, you need to make sure that one purpose is super, super necessary, right? As opposed to something that, you can use for bleeding or splinting, or you can use for chest seals, or for, I don't know, chest seals is kind of a bad example. It's pretty specific.
Well, that actually kind of brings up a good point, about improvisation. There's a balancing act here. I've known lots of guys who are like, well, if I have duct tape, a Swiss Army knife, and a belt, I can do anything that a emergency trauma team could do. Bullshit, not true, right? On the other hand, I know plenty of guys who have like basic CPR training, but they carry a backpack full of like expired IV bags, and that doesn't get you there either.
Scalpels,
right?
Yeah.
You need to go get the training first, train with the equipment you're going to use in real life, which often means you might need to buy 2 sets, 1 set to train with, 1 set to use in real life. You need to have it staged. You need to balance saving space versus being able to get to it. If you leave it in your car, you need to think about things like shelf life. In fact, if you leave it on a shelf, you need to worry about things like shelf life. And if you leave it in a place like Arizona, where it's 5,000 degrees out, it's going to have a certain shelf life. If you leave it in North Dakota, where it's minus 5,000 degrees out, it's going to have a different shelf life. So account for that in what you buy and how you stage it and how you pack it.
Yep. And one last pet peeve that I want to make sure that we hit in this episode for the sake of calling it complete is tourniquets. The Committee on Tactical Combat Casualty Care and the American College of Surgeons Committee on Trauma write and publish a lot of advice on dealing with trauma. If you're going to buy a tourniquet, it needs to be one that is recommended and approved for its intended purpose. There's a lot of stuff out there that some YouTube guy shows how well, XYZ tourniquet does of a job of occluding and working and being effective, but it's 2021. They've had every opportunity to get on the approved list of gear that the Committee on Tactical Combat Casualty Care has put together of tourniquets that have been proven to be effective and easy to use. It needs to be one on that list. The CAT is the easy. North American Rescue makes the CAT tourniquet. That's like the standard. TAC Med Solutions makes the soft T wide. That's a standard. And for a long time, they were like the only 2. And now there's like, I don't know, probably 6 others that are on that list that are all fine. They've been tested. They're recommended by those committees. Those are your answers. Okay. One of these elastic bands that wraps around and does whatever, if it's not on the list, then they haven't gone through the motions that they need to go through to carry that thing. So I don't care about how comfortably it fits in your pocket or how convenient it is, or that some
super secret ninja carried
dude,
it doesn't matter.
Some guy who claims to have a background was able to make it effective on YouTube with a little Doppler, no. Get one that's approved. An approved tourniquet, period. Full stop.
I like CAT. I've trained with it. I grew up with it. That's what I carry. My suggestion on it is if in doubt, if you can't decide between them or you watch too many YouTube videos about them, get the CAT, start with that. And then as you get more training, you get more comfortable, then work out from there. Another thing I don't want you to forget about is just basic first aid stuff. Basic stuff. Band-Aids, Neosporin, aspirin, drip drop oral rehydration solution, water, an ice pack, like an instant cold pack, super glue for some cuts, right? Think just basic first aid stuff, because it's amazing what kind of injuries you're going to see. Something sweet like Lifesavers with real sugar in it, for diabetic type things. Keep like an owie kit along with all of your serious trauma stuff, right? Think about the most likely versus the actual most dangerous.
As far as one thing I want to hit on, just for the like something sweet diabetic stuff, you could buy like tubes of oral glucose. It's disgusting, but think about something that if someone was out of it and kind of easy to swallow. My kid really likes those like applesauce packets that you can, like Costco's got the like Go Squeeze, a little squeeze thing that you can take applesauce out of, something like that, where it's got simple sugars in it, but it's also easy to swallow and they're not likely to choke. Again, another topic for another day, but all right. In review, I know we spent a lot more time talking about big picture stuff than actual trauma care, but that was a little bit on purpose, because trauma care is more than just memorizing what March stands for. And it's more than knowing how to slap on tourniquets and chest seals, the box and the junctions and the arms and the legs. Yeah, those are fundamental skills. They're definitely building blocks. They're puzzle pieces to trauma care. But bigger picture, we need to deal with solving the problems that present themselves and getting the person or our patient to definitive medical care. And operational planning and risk management will help us build the right state of mind, if nothing else, just logistically in accomplishing that. The big picture considerations as they relate to the equipment that we need to carry, the transport, how we're going to get wherever we need to go, and how much skill or expertise or staffing or number of people that need to be available to help with these problems. That all happens long before March becomes a factor. Long before you're walking up to the blood and the guts and the chaos comes all of those thought exercises that we've done ahead of time, before the day that it became a factor. The most important question to ask yourself when you're dealing with all the blood and guts is, what is going to kill this person? Yeah, you got some tools and you got those mad skills, and you should certainly use them when it's appropriate. But you need to go one step further, consider the limitations that you have and that you're stuck with, so that you can coordinate the next steps, which is in a lot of ways more important. And finally, dealing with trauma, like any component of survival or everyday carry or anything like that, is not a kit, right? You've got to see this from the balcony view. It's all about your decision-making and your training and your preparation. So don't get too wrapped up in the gear. Think about the bigger picture.
And my final thought on it is, with all disaster preparation, human nature is you want to be able to check a box and say you're good. Oh, I've got a tourniquet. I'm good. I took a first aid class 5 years ago. I was a lifeguard. I'm good. I got this. I appreciate your confidence. I'm going to tell you, you're not good. And this podcast doesn't make you good, right? A podcast ain't going to make you a medic, obviously. And from a liability standpoint, obviously, we're not giving you actual medical advice. What we are is giving you some insights to go get more out of the training you go get, right? So we want to motivate you, go get training. We want you to think about it before you go. We want you to get more out of the stuff that you actually sit through, and help inform your decisions and refresh you once you've had it. So go get the training. If you're not sure what kind of training to go get, figure it out. If you don't have anything, take a basic CPR class. If you've got the basic CPR class, go find a tactical medicine class or a TCCC class. There are a lot of sources out there. Google TCCC, that'll be a good start. Another one that I learned a lot from was pre-hospital trauma life support. And that's typically intended for full on professional medics, but that doesn't mean you can't read about it. That doesn't mean you can't learn about it. It's not a secret. Okay. So go learn.
And it's written by the same people that do TCCC. The same committees put PHTLS together, and that's like the civilian version of trauma, pre-hospital trauma stuff. If you are looking for input on classes or training to take, feel free to reach out to us and interact with us. The best place to do that is on Facebook in our podcast discussion group. Go to the Facebook page at TAC Tangents and look for the podcast discussion group in the groups tab, and we can answer questions and we can talk all about it all you want. You can also email us info@tacticaltangents.com. We want to get you guys the good stuff. And so if you have a doubt or a question, reach out and we'll help you out the best that we can. This episode is brought to you by Dry Fire Mag. Dry Fire Mag solves the common and annoying problem of having to rack the slide every time you pull the trigger in dry fire training. With the Dry Fire Mag, you build good habits by having a trigger that will reset so you can prep for the next shot without taking your other hand off the gun. Go check them out at dryfiremag.com.
This episode is brought to you by Ride-On Optics. Ride-On is a scope manufacturer. They specialize in high-quality optics at reasonable prices. They're all about customer service, and they're doing great work supporting law enforcement and the veteran community, so we hope you check them out. You can find them on ritonoptics.com. Ride-On Optics.
Don't forget that we put out new episodes on the 1st and the 15th of every month. If you like what we're doing, you can head over to Patreon and give us $1 for each new episode. That money is going to go back into giving you good content. And we already covered all the social media stuff at TAC Tangents on Facebook, Instagram, and Twitter. You can also email info@tacticaltangents.com, and that's all I got.
Be safe out there. The best solution to all this is don't get hurt. So do that.
Whole other phase of discussion. But all right, that's all we got for now. Good talk.